This is a case of a 70-year-old male who actually went to the ER with complaints of abdominal pain. And so in the workup, he underwent a CT scan for this. And the CT scan was notable for a right renal mass with associated lymphadenopathy. There was a concern for a lytic lesion in his spine. He subsequently underwent a CT chest, which showed innumerable sub-centimeter pulmonary nodules with associated hilar lymphadenopathy. He was referred to urology, where they elected to undergo a biopsy of the abdominal lymphadenopathy, which revealed clear cell renal cell carcinoma without any sarcomatoid features. His past medical history was notable for a history of ulcerative colitis, as well as hypertension, and labs were notable for essentially normal chemistry with a CBC showing a mild anemia at 12.5 with no thrombocytosis or neutrophilia. This is obviously a common situation. Patient presents with a new diagnosis of renal cell carcinoma, and we always have to ask ourselves, what's the best way to treat these patients? And I think really with the advent of the data regarding target therapy combination with immunotherapy in the modern area, really looking at risk stratification is going to be important. And so the one I often use is the IMDC risk stratification, which takes into account clinical factors of the patient that were developed really in the era of TKI, but really are showing to have an important role in the era of immunotherapy. And so this is going to involve looking at the patient, how the performance status, as well as lab values. I'm looking at the CBC, looking for neutrophilia, thrombocytosis, anemia, looking for elevated calcium, and really trying to get a sense for that patient, and obviously do they need therapy or not. So in this patient who's presenting with metastatic disease, if you're going to pursue therapy, I would say he has intermediate risk disease by the IMDC criteria.